So we got 77 million baby boomers coming at us. It's the healthiest generation. We have money follows the person. We have nursing homes closing down. And we know that the health curve for these people is pretty good. But once they reach a certain age, all of a sudden it's going to be like that. The slope of the curve is going to look like that. Where are all these people going? Who are they going to talk to? Well,
that's a load of. We have 10,000 people a day turning 65 in this country now, and you're right. The tsunami is going to hit probably in 15 years, plus or minus, as we get into our late 70s, early 80s. I think where we go is to start the conversation with our children, start the conversation with our nieces and nephews as far as what our wants, what our needs, what our desires are as we age. Again, so that the people that will be responsible for us, which are our relatives, hopefully our adult children, will know what our expectations are, what our desires are, again, in a calm discussion rather than in an emergency room situation where the emotions are very high.
And I think that it's important to note that long-term care services and supports, as you alluded to, are for people of all ages. It could be Dawn and I tomorrow. It could be the second we pull out of this parking lot. So the conversation is really for everyone, and the systems change that we're talking about here is really going to benefit everybody.
My concern is that based on the experience that I just saw in Florida, that much like anything else, if you're a younger person, and I'll define younger is below 35, all right, you're never going to die. You don't think about this kind of stuff, right? Between 35 and 50 to 55, you begin thinking about it, but you know what, Steve? Most people don't do anything about it. Correct. And there you are, you're looking at these older people, and many of them don't have any sort of child support system or any support system around them. All of a sudden they have a bout with the hospital, they're coming out, and there they are, being made to understand something they can't even begin to understand. So my concern is, given all this good stuff that seems to be happening, how are they going to know what to do?
Well, it's like I said earlier, you have to think in advance, and we don't do a good job in the society of thinking in advance, but you need to start when you're in your 50s, thinking about your future, thinking about what is life going to be when you're 85 and 90. And you need to begin that planning and discussion process. You need to look at long-term care insurance as another example. I mean, that can help.
It's good insurance, relatively expensive though, Steve.
It's expensive as a relative term. If you need it, it's inexpensive.
Right.
So
yeah, I'll buy that.
So, you need to have the discussion. You need to plan. You need to think, because we're not going to be in the same health condition we are today tomorrow.
Okay, so let's simulate a bit.
Sure.
All right, let's simulate money follows a person, and we have people who are doing certain things now, and here comes money follows a person, right? And you had this demonstration project going on, etc. So where are these people going to? And when I say going to, when I hear that people may be able to go into the community, my term, not yours or Julie's, Dawn, my concern is it's kind of like an amorphous blob. What is this thing called the community? What do they go into? Because past the community is staying home, being cared for in their home. Does money follow the person reach all the way into the home?
Almost every time. That's people are either going back to their family home, or going, if they don't have a home, we are going out, finding an apartment or a home for them, renting it, setting it up for them, helping them with pots and pans, putting things back together, because sometimes if people have been in a nursing home for a while, they've basically lost everything. They don't have the resources to be able to pay for it. So back to an apartment, back to a home, and about 85%, we've moved out 1,000 people in 3 years. And
your goal is what, like 5,000 or something like that?
5,000, and we have not rolled out our expansion yet, and I feel very confident that we're going to hit our targets, maybe even exceed the 5,000 target.
Okay, so at the micro level, which is where we are now, this demonstration project, let's go up one level, right, to the macro level, and let's talk the United States of America, right? I'm guessing that what you were saying before was, if we realize that 40% or 20%, they're hundreds of billions of dollars, right? If we realize these savings, what we had better do is take those savings and plow it back into some of the things you're talking about, like housing.
And I think we're doing some of that in the department, and I think some of that is in the governor's budget that we saw. The governor's budget had about $12 million for building more accessible, affordable housing for people over the age of 60, had money to help work with nursing homes who want to diversify their business model and help deliver home and community-based services. Because back to your point about the baby boomers, we're anticipating right now, we've had actuaries study this, we've developed a plan inside the department, or at least we have recommendations ready for our commissioner, and we're expecting that we will need to serve 25,000 more people in Medicaid over the next 15 years. We're expecting that 32,000 more people will be choosing home and community-based services, and we do think there will be less demand for nursing homes as we eliminate the barriers that prevent choice.
So we call that nursing home diversion, or that's what's on my mind. One thing I would like to see, wearing my Commission on Aging hat, is to have better access to services before you go into a nursing home through the range of Medicaid waivers that we have in the state. And so I think that's important that we recognize that, and we're going to continue to have that discussion with the administration.
But you know what, Julie, is the Executive Director of Commission on Aging, you're out and about all the time. I mean, you talk to a lot of people, you serve on a lot of different commissions and boards, et cetera, and among the ones you do, the Commission on Aging is the workforce development. And I mean, to translate that into something that the audience can relate to, one of my other concerns is, where are all these resources going to come from? They're going to take care of all these people. And let's start with the people first. I mean, when I left Connecticut several weeks ago, I was reading an article about the nurses were very, very upset because in order to make the program less expensive, people other than RNs had to be able to do things with medication and perhaps give a needle or what have you. And they're saying, no, 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 no. You cannot do that to people because you're interfering with their quality and the safety of the care. So there's that, and there's also the number of people you're going to have just this. Where are they all going to come from? Right. Who's going to train them, Julie?
Right. So we've been heading up, as you referred to, the Workforce Development Initiative. There's a wide range of initiatives. One of the things you alluded to was the Med Admin, and Dawn has been the person working on that for several months, who administers the medication, and it's received a lot of attention, and they've been working through some differences. And I think we need to revisit. Part of what we're doing is looking at what types of services individual providers can provide. We need to look at our regulations. There needs to be a whole vetting process that we need to revisit. But part of it is, I'm just going to state the obvious. We have younger people leaving the state. We have our elder population increasing. Yeah, right. Increasing by leaps and bounds. You mentioned the baby boomer. So what are we going to do? And we actually have to have the discussion about how we're going to value caregivers, unpaid caregivers, and those who are paid. And a way that you value them is by paying them adequately and giving them proper benefits and supporting the caregiver who's doing this because they love their, their parent or their child.
Right. And I just want to go back to medication administration. Actually, our discussion right now doesn't include injectables. So that's we're talking about oral medication, topical medication, or eye drops. But right now in our system, we do see this as a major issue that can stand in the way of rebalancing, because currently only a nurse can administer.
Do you want to define rebalancing?
So changing the allocation of funding between home supports and institutional supports specifically to allow the individual to have a choice. So as more people choose community, rebalance means more money will go to community to support that. Because if we don't fund the community, even though I choose to go to the community and a nursing home bed is open, my only choice is to go to the nursing home.
Let me jump ahead and say, if this thing were in full force, this 25,000 or 30,000 people you're talking about, over what period of time do you see that?
15 years.
Over 15 years. So that means in the next 15 years, these kind of people that you're talking about, Julie, medical administration people, they're one level lower, and I don't say that in a deprecating sense, than nurses, for example, and all the other people that are needed to be taking care of people. 15 years sounds like a long time, but given the number of people you're talking about and what you're going to have to go through, and we haven't even talked about the law of unintended consequences, right, of what's going to happen here, this is a big, big change.